All right, now let's talk about the consequence of renal failure. You have decline in renal. So they're talking about the consequence of renal. So you have renal failure, or the kidneys are not working. So what's going to happen now? So you have decline in renal filtration that can lead to excess retained nitrogenous waste products and electrolyte disturbances. Consequences are mad hunger, metabolic acidosis, dyslipidemia, which causes increase in triglycerides, high potassium, uremia, sodium and water retention, heart failure, which leads to heart failure, pulmonary edema, and hypertension, growth retardation, development delay, erythropoietin deficiency, anemia, renal osteodystrophy. Okay, so these are the consequences of renal failure. Now, the important ones are here that. So, what are the? Let me just put it in here. Electrolytes. In electrolyte, you will have an increase in potassium, the phosphate, the magnesium. So when you increase the phosphate, you know what you're going to decrease the calcium. So those are the electrolyte disturbances. Anemia, because EPO is not going to be coming. EPO comes from where? EPO, erythropoietin, comes from the renal peritubular interstitial cells in the PCT or PT, right? So when you have the kidney is not working or it has failed, it's not going to produce EPO. It's going to cause anemia. It's simple, right? In uremia, they haven't mentioned much, but let's talk about uremia here. Uremia, you are going to have first of all, you will have nausea, anorexia, and all that, but you will have pericarditis, asterexis, which is the flapping of the flapping of the hand at the wrist, encephalopathy, and platelet dysfunction. Because of uremia, you're also going to have a platelet dysfunction, because uremia inhibits platelet aggregation and addition, which is going to cause bleeding, mucosal bleeding. Okay. Neutrophils even don't degranulate. Uremia inhibits neutrophil degranulation, which will lead to infections. Okay, that's with all uremias and all that. Why do we have high potassium? Because we have no excretion of potassium. That's why we have high potassium. Why we have metabolic acidosis? Because we cannot excrete the organic acids, which leads to anion gap metabolic acidosis. Okay. Okay, something that they haven't mentioned, or maybe they mentioned. Oh wow, they have mentioned something. Uremia. Let's read uremia first. Syndrome resulting from high serum urea can present with pericarditis, encephalopathy, seen with asterexis, anorexia, nausea, and European, whatever. But they haven't talked about inhibits the platelet aggregation, which leads to bleeding, and inhibits the neutrophil degranulation, which is infections. That's with the uremia. Okay. Let's now talk about. So we did talk about this sodium and retention, because sodium is not even going out. So wherever the sodium goes, the water follows. So you have so much volume, increase in volume, that cause heart failure, or can cause pulmonary edema or hypertension, growth retardation, and developmental delay. So here's what we need to talk about. So first of all, there's when you have a renal failure, you have decreased conversion of T4 into T3. Decreased T4 to T3 conversion. Which leads to functional hypo. Because you can't convert this, so you can develop functional hypothyroidism. You can also develop pruritus because of deposition of the urea crystal under the skin due to increase in urea. Again, one urea, right? Which leads to pruritus. So yeah, that's pretty much what we have. Let's read now on the right side of it. Okay, two forms of renal failure. We have acute, for example, ATN we talked about, and the chronic, which is due to the hypertension, diabetes, or congenital anomalies. Incremental reduction in GFR defines the stages of CKD. Normal phosphate levels are maintained during early stages of CKD due to increase in fibroblast growth factor 23. Okay, where this came from, I will tell you. Which promotes the renal excretion of phosphate. How does it do it? I will tell you. FGF23 fights phosphate. Okay, now let's talk about this thing what they have mentioned. Okay, so here when we have CKD, chronic kidney disease, we basically there's a prolonged, we said with GFR, where we have the decrease in GFR, right, or prolonged decrease in GFR, or we said here when they actually mentioned that there's the incremental reduction of GFR, and that defines the stages of CKD. Okay. Now, this is very important, guys. Just pay a little attention here. CKD, when you have a decrease in GFR, now guess what's going to happen? Because of CKD, now you're having two problems here now. So you have a decrease in the active form of vitamin D, which is calcitriol, and you have a phosphate. We said high phosphate, right? We have that's potassium, but there's a phosphate. It gets excreted from the kidneys normally because now we don't have the kidneys. So phosphate is going to be is going to increase, or it's going to get retained, and we have decrease in vitamin D, which is calcitriol. Now this vitamin D, because we have decrease in here, it leads to decrease in intestinal calcium absorption, which leads to decrease in serum calcium. That's one thing. Wow, why can't I write? Sorry about that. My pencil is not. Okay, now it's good. Great. So, decrease in serum calcium. When we increase the phosphate, guess what's going to happen? That phosphate is going to bind the free calcium that is in the blood, okay, and causes more decrease in serum calcium. So in two ways, we are basically having low serum calcium, right? And that increase in phosphate is doing two things. That increased phosphate binds the calcium and precipitates in the soft tissues, right? But over time, this phosphate this phosphate causes vascular calcification because it's binding to the calcium. So calcium, they both then calcify the vessel. Okay, they calcify the vessel, and it causes, when you calcify the vessel, it causes stiffness of that vessel. That leads to release of fibroblast growth factor 23. So when that releases, sorry about that, guys. That fibroblast growth factor 23. Now this causes, if they have mentioned, that would cause the excretion of phosphate. Okay. So that's one thing. Let's talk about, we should know that there is a decrease in serum calcium. There's another associated disorder where the serum calcium is decreased. So let's talk about the next thing, which is the renal osteodystrophy, and I'm gonna tell you how the calcium is messing up there. Renal osteodystrophy. You have the hypocalcemia, again this thing right here, hypocalcemia, hyperphosphatemia, again this thing here, and the failure of vitamin D hydroxylation, which is this thing here. Okay, associated with the chronic kidney disease, and yeah, CKD causes all of that, right? Which leads to, now it causes, now let me change the color. Now this causes all of this decrease in the calcitriol. What is that? Because you can't activate it from 1-alpha hydroxylase, right? Because the kidney does that. You have increase in phosphate because you can't excrete it out, and all of them are causing decrease in serum calcium, right? And all of that, when you decrease the calcium, let me just do this thing. That decrease in calcium causes, with secondary, now that serum calcium causes hyperparathyroidism. It goes, well, the parathyroid senses the calcium. It says, oh wow, I don't have calcium in the serum, so it causes hyperparathyroidism. Parathyroidism, right? And that is secondary to the fact that we have decreased the calcium. That's what's called secondary hyperparathyroidism, which causes tertiary hyperparathyroidism if secondary is poorly managed. That needs a little bit details, so I'll tell you in a bit. The next line is high serum phosphate binds the calcium, which leads to tissue deposition. Again, same thing. Those phosphate binds the calcium, goes to tissue deposition, and decreases serum calcium. Decrease in D3, which is the calcitriol, causes decrease in calcium, interstitial calcium absorption, and causes subperiosteal thinning of the bone. Okay, that's the osteodystrophy. So now let's do it our own language now. We have read what the book said. Let's read now. So you have a decrease in serum calcium, and that is from all of the facts that we talked about. And that decrease in serum calcium causes increase in PTH, parathyroid hormone. And this is secondary to the fact that we have this decrease in serum calcium. Now that increase in PTH, let me actually write increase in PTH here, is going to do two things. Well, it's going to cause increase in bone resorption, right, and get the calcium back. And if it's going to do that, then it's going to cause osteoitis fibrosa cystica. Okay, but if in some cases, if you develop resistance to PTH, now you have a dynamic bone disease due to osteomalacia. Okay. So in CKD patients, you administer them with this calcitriol and the calcitriol, which is the vitamin D, active vitamin D, this thing, and the calcium supplementation in CKD, and that would often return the PTH levels to normal. But long-standing CKD, PTH release become independent of the calcium levels. Long-standing CKD, the PTH becomes independent due to chronic stimulation of the due to chronic stimulation of PTH because of low calcium in the blood. Okay, so that's what we have for the renal osteodystrophy, renal disease causing osteodystrophy, bone disease, by causing secondary and tertiary hyperparathyroidism, and due to the fact we have low calcium and all that. So that's the renal osteodystrophy. So so that's all for these two things. But let's talk about something extra, which is the phosphate. That phosphate, which was high, right? That phosphate in patients with CKD. So I told you that we can give calcitriol, we can give calcium, but also we can give something called oral phosphate binders. And also limit the intake of. So this is actually the treatment. So if you have a patient with CKD, what are the things that you will be giving? Well, the first thing is calcitriol, which is vitamin D. Second thing is the calcium. Third thing is phosphate binding raisins or oral phosphate binders. What do? They are going to not let the absorption of the phosphate and also limit dietary phosphate intake. Okay. Now those in the phosphate binders, one of the drugs that we have is the sevelamer. It is a non-absorbable anion exchange agent that binds the interstitial phosphate and doesn't let it absorb and lets it get excreted in the feces. Okay. So that's pretty much what we have. On top of this, these are all the treatments, remember. And on top of this, we are going for dialysis, the renal transplant, thinking about that. Cysts in the CKD, cysts often develop within the shrunken kidney during dialysis. there's a risk of, if the cyst does develop, there's a risk of RCC, renal cell carcinoma. So when you think about cyst again, let me just also mention about the cyst. When you think about cyst of the kidney, cyst in big kidney, meaning normal kidney or big kidney, that's the PCKD, polycystic kidney disease. And cyst in the shrunken kidney, it is seen in the chronic renal failure. That's just to memorize, easy way. So that's all we have for this renal failure and renal failure consequences.